this morning. He serves as Executive Director of the National Association of County Behavioral Health and Developmental Disabilities Directors. He's Executive Director of the National Association for Rural Mental Health, Adjunct Professor at the Department of Mental Health, Bloomberg School of Public Health, Johns Hopkins University, and Adjunct Professor at the School of Social Work, University of Southern California. We won't hold that against you. Dr. Manderscheid's career is quite distinguished, and his bio is complete in your programs. He has authored a number of publications on the topics that we're mostly interested in here today. And rather than taking up more of his time, I'm going to step out of the way and ask you to help me invite him to the podium.
So good morning to all of you.
Good morning.
So this is the third time that I've stood at this podium at exactly this time in your meeting, and I'm delighted to be invited back to be with you. And I'll tell you a little story about that. When I was a freshman in college, I took a course in public speaking that met every Friday morning. There were 23 people in the course, and everybody in the course gave a talk every single week. And the prof said, you're going to talk exactly 1 minute. When the 1 minute's up, I'm going to hold up the card. You stop right on whatever word you're on and sit down. And of course, people said, well, how could you possibly make a point in talking only a minute or less? I said, not important, not important. The critical thing is to be invited back. People won't remember a single thing that you said. So now I have about 37 seconds left in this talk. Okay, so I'm delighted. Thank you to the Department of Mental Health, the Department of Public Health, the Department of Health Services for inviting me. And thank you to these departments for putting this meeting together, because this issue is just absolutely critical to behavioral health care. So let's see here. Disclosure, I have nothing to disclose. I have no financial relationships. I have no off-label use of drugs that I'm going to talk about and so on, which is required for your CME credits. I want to spend a second remembering all people who have died prematurely as a result of the opioid problem. And I want to add to that Dr. Sandra Naylor-Goodwin and Dr. Rusty Seelitz, who were not only major figures in California, but also national figures as well. So I want to spend just a second thinking of that. Okay, so to move in then, imagination without execution is just fantasy. So we can talk all day long about integrated care. The problem is, how do you do it, and how do you make it work, and how do you pay for it? Talk about integration without execution also is fantasy. So when you talk today, put an action spin on what you are actually saying. So again, without any doubt, the key issue of confronting behavioral health today is how we are going to effectively do integration. And it's not simply integration of behavioral health and primary care. It's also integration of mental health and substance use. And in fact, that may be the more difficult problem that we are confronting here. The problem of social justice, I don't need to tell you that the behavioral health field is disparate. So the clients start with health status inequities and health care access inequities. Providers are inequitable in behavioral health compared to health services, and the field is inequitable. So we have a whole set of building to do, all the way from our clients to our providers to our systems, so that we are on an equal par with other entities in the healthcare field. That's an issue of social justice. What social justice is designed to do is to remove disparities and move toward better equity. So I'm going to take you through what I hope is a thrilling ride here. And we're going to hopefully see many things, and hopefully we won't crash in the process. So I want to do several things. So as I said, I've been here twice before, so I want to do a little bit of review. What's the policy context? What's the status of practice implementation? I want to go into some emerging challenges and opportunities, and looking a little bit toward tomorrow on some of the things that I think will help ease the problem of care integration. So first, policy review. So in the middle 1980s, we rediscovered, through research that was being conducted at the National Institute of Mental Health, the fact that persons with behavioral health conditions get chronic health diseases earlier, and those chronic health diseases are more severe than is the case for other people. That, in effect, was a replication of studies that were done in the 1920s that showed very much the same thing. I would say prior to 1985 in NIMH, we paid virtually, and I was in the staff of the National Institute of Mental Health at that time, we paid virtually no attention to the chronic health problems of people with mental illness. None. There was nothing in the training, there was nothing in our programming, there was nothing in our grants, there actually was nothing in the research that was going on in NIMH. So that was a real eye-opener for us in the field, and I guess our eyes should have been opened before if we actually read the literature from the 1920s, but it was an eye-opener at that time. That then prompted a number of things to occur, which still haven't completely occurred today. The concept of a primary care physician as a case manager for someone who has a behavioral health condition. Another paper written in NIMH at that time. We then go on, many of you will remember the Federal Community Support Program. Community Support Program was developed in NIMH for adults with serious mental illness. The purpose of that program was to bring together 10 essential services using a care coordinator or case manager. Not that we manage the services, the role of the care coordinator would be to reach out for housing, reach out for SSI, DI, reach out for dental care, etc., and put that package of services together. It was always, the way I described that was the poor person's version of integrated care. When you don't have the money and you don't have the power, you then fall back on some version of care coordination, which is exactly what we did. That program, the Community Support Program, became very successful. Nationally, virtually every state adopted that program, and I bet you I could go to the state of California today and still find remnants of that program, 25, 30 years later. But it set the stage for what we were going to do. It was out of that program that came the concepts of care coordination. It was out of that program that came the concepts of having peers at the table working with us on major issues and so on. 1998, the Surgeon General's report on mental health, Surgeon General Sapcher did the very first report in 200 years on mental health, and the whole concluding chapter of the Surgeon General's report on mental health was the next decade of work for mental health is going to be solving the problem of integration. He said that in 1998. That chapter probably deserves rereading at this time because it's now, well, 2 decades beyond this, and we're still in process here. In 2000, he convenes, Surgeon General Sapcher convened another meeting at the Carter Center with a focus on integrated care and what the appropriate role of the federal government was in integrated care. I had a good opportunity to participate in that meeting. It was a very good meeting. A number of very well-intentioned good things came out of that meeting. The Deputy Surgeon General of the United States was assigned the task of executing these things, and I was assigned to work with him on this, and after 2 years, that man took his hand, threw up his hands, and said, I can't move the agenda of integrated care in the federal government because I can't move the federal agencies. He was talking about SAMHSA, HRSA, CMS, CDC, etc. And some of the same things I'm going to talk about in a few minutes affected the federal government. The basic fear here, if you do this, your organization is going to disappear. The fundamental bureaucratic fear always is my organization is going to disappear into something else. And we need to talk about that. So that special report is available if you want to read that. A lot of the things in that report are still relevant. That's up on the Surgeon General's website. 2003, President's New Freedom Commission on Mental Health. There can be no good health without good mental health, and there can be no good mental health without good health. Fundamental, very first principle in the President's New Freedom Commission report. Again, that's all well over 15 years ago. 2005, the Institute of Medicine report on improving the quality of health care for persons with mental health and substance use conditions. Mady Chalk and I had the good opportunity of being the project officers on that project. And so the people at the Institute of Medicine say, what does the government want? And we said, the government wants a very practical report that people in the field can use to implement integrated care. And I would say we got 85% of what we wanted. I would say that report is as relevant today as the day it was written, and I commend that to you for practical advice on implementing integrated care. 2006, research on excess mortality. This is research that I myself did. And we had a sample of 8 states. We had 100% data on 8 states for 3 years. And we processed the data, and the bottom line was public mental health clients die 25 years younger than other people. So when we first had that, I said, well, that finding can't possibly be correct. You know, we need to go back. We've done something wrong in the analysis. So we re-looked at the analysis. The analysis was correct. The number was correct. That data was published in 2006. And there's 2 features to it. One is 25 years premature. The other feature of it is these people die of exactly the same thing everybody else does. It's just 25 years earlier. Classic case here. So this year, 616,000 people are going to die of a heart attack or stroke in the United States. 200,000 of those 616,000 people will be people who have a primary behavioral health condition. So people with behavioral health conditions die of exactly the same things other people die of. They just die very much earlier. So if I take mental illness in public mental health sector, it was about 25 years. If we add to that substance use, we can get the numbers up to about 35 to 40 years. So for mental health clients, you see many people, many peers dying in their early 50s, supports that basic findings. You see people with substance use conditions and mental illness dying in their 40s. It's a tragedy, absolute tragedy. So those findings had significant impact on the field. It was shocking to the field to hear that number. In this field, we pride ourselves on doing good for people. And in this instance, you know, I think we were failing them and pretty much continue to fail them on this account, basically. So a primary motivator of integrated care is the fact that we need to address the chronic physical health problems that people have. 2008, the Mental Health Parity and Addiction Equity Act, very important here. And basically what that act says is that your insurance benefits for mental health and your insurance benefits for substance use must be at parity with your insurance benefits for primary and health care. There are many bells and whistles on this. I guess my own personal side comment on parity is very important. It continues to be important. It probably should be extended to include a whole range of other things beyond insurance. We should be talking about parity in access to care. We should be talking about parity in outcomes from care. There's a whole additional agenda for parity that we haven't even begun yet. But if I simply stay with insurance, I would say we've had middling success in implementing parity. In California, New York, and a few other states, your attorneys general have taken this issue on and actually bring cases where they find violations of parity. I would say one of the problems in implementing parity is a very simple concept was made incredibly complex. Who in the room can describe for me what's meant by non-quantitative treatment limitations? Non-quantitative treatment limitations. So, not only must the benefits be at parity, but the non-quantitative treatment limitations must be at parity as well. And there are many, many paragraphs and pages and analyses written of non-quantitative treatment limitations, basically. 2010, the Affordable Care Act, and I think, had we not been able to do parity, we would never have been at the table in the Affordable Care Act. So you can thank Patrick Kennedy, Representative Patrick Kennedy, and his father, Senator Ted Kennedy, for the parity legislation, and you can really thank them and the work they did, and the work that people in the field did on parity to get us to the table in 2010. I would say in 2010, and all the years I've been in the behavioral health field, is really the first time we are really at parity with other fields at that table. The critical thing of the Affordable Care Act for our purposes here was that it has specific features. Section 2703, which I will mention in a little while, speaks specifically to the creation of health and medical homes and providing resources for health and medical homes. Another feature of that legislation, which is less obvious in the wording of the legislation, the Affordable Care Act moves the agenda of person-centered care. Person-centered care is very friendly to integrated care and vice versa. Integrated care is very friendly to person-centered care. Person-centered care and the concepts associated with it are helping to move us now in the direction of self-direction in care and self-determination in life. So the current agenda we're working on nationally is how do we move toward better self-direction in care by peers, basically. Moving ahead here, 2016, value-based purchasing. So if you're not in value-based purchasing, you will hear about it soon and you will be involved in it. Value-based purchasing has two concepts. Concept one, it's a capitation-based system. So I would start, if the people in this room constitute my group, I would say my group is 1,100 people, and these 1,100 people are going to receive care through my organization, Organization A, and I'm going to provide all the care that these 1,100 people need, and I'm going to get a capitation payment of $2,500 a year times 1,100 people to do that care for this population. That's a capitation system. It's not based on use, it's based on anticipated